Hello everyone, welcome this evening to our webinar on managing complaints in primary care. I am Dr. Clare Sweeney, and with me tonight is my colleague Dr. John Dale Skinner. We're both GPs by training. John worked in London for some years and I was a GP partner in Northern Ireland for about 20 years, so we have hands-on experience of general practice and how complaints are managed there. We would encourage you all, we want to make this as interactive as possible, so there is a questions section in the little control panel. So if you could start to get your questions in there as early as you possibly can, anything on the subject of complaints, and if you keep them as concise as possible, we will try and bunch up as many as we can. We're going to hopefully spend 15 or 20 minutes at the end of the presentation dealing with your queries and your concerns. There are certificates of attendance. They will be emailed to you within the next 24 hours, just to say that you've been here. When you log out tonight, you will get a pop-up a feedback form, and we would really appreciate it if you would take 2 minutes and fill in the form, because it really helps us to plan and better target our future sessions. So I'm going to hand over to John. John's going to take you through the first half of the presentation, and then I'm going to join back in later on. So John, over to you.
Thank you, Claire, and good evening, everybody. So we'll start off with having a look at the objectives, what we're going to cover today. Going to look at some statistics about complaints in general practice. And hopefully by the end of the session, you'll be in a position where you've got a really good chance of resolving complaints that your practice receives or that you might be named in, and hopefully resolve them the first time. We think it's quite helpful to discuss a bit about the law and regulations relating to complaints, because of course these underpin what we do, or the complaints procedures at your organisations, so that can help us understand why we are doing certain things in a certain order when we're dealing with complaints. And hopefully you will leave tonight with some top tips on good quality complaint responses. And we will also discuss what can happen when a practice isn't able to resolve a complaint as well. So a few statistics about how many complaints the NHS receives, and this information is available on NHS Digital. Some of you may have looked at it before, and it is quite interesting data. About 45% of the complaints that the NHS receive are about general practice. Reassuringly, about half of them are not upheld, so no fault is found. And of course, that's our experience when dealing with complaints, is that often the response is an opportunity to explain to patients or relatives who might be making a complaint what went on in the clinical sequence and why. And you know, that's one of the aims of a response, is to explain that clinical sequence, which sometimes the complainant has misunderstood. And that's often enough to resolve a complaint, along with responding to the points of concern. So I would suggest you have a look at these statistics if you've got time, because the NHS actually splits them up into different types of complaints, and you'll see that I've drawn some of the different topics of complaints into that pie chart. And you might be thinking, well, clinical treatment, that's 13%. I mean, surely it's higher than that. And then you'll see the 40% is other topics of complaints. And of course, these statistics have to be read in the context of, or we have to appreciate that sometimes, or a lot of times, complaints have more than one domain. So it's not just clinical treatment, it might be delayed diagnosis. And there is a whole list in the spreadsheet that the NHS produces listing these different domains. But I thought one aspect of this which was quite interesting was the communication and the values and behaviour complaints. So they make up just over a quarter of complaints in general practice. And of course, those are sometimes some of the easier complaints to reflect on and think about what quite simple things can be done to improve the communication between practice staff and patients. And it's also to highlight that, you know, a lot of the complaints we deal with are not always about the wrong diagnosis or a delayed diagnosis or a medication error. You know, communication, values and behaviour are important as well. And I'm sure those of you that handle complaints in your organisation, if you have the role of responsible person for complaints, then this is probably going to be consistent with your experience. And it's always important to think about that patient journey going through your organisation and who actually sees the patient. And of course, we sometimes see in complaints that it's not always the clinician who the complaint's about. It might be somebody at the front desk, an administrator, for example. So we'll move on from the statistics, and I thought we'd start early on with one question for you all. So this is our first poll, and I'd be grateful if you could complete it. What worries you the most about a complaint made to your practice about your care of a patient? So if you could just complete that, and let's see what we get. Okay, so I can see that certainly a lot of you, around 60% of you are concerned about all of those things, and we appreciate why you would be, and we'll come on to how a complaint may develop into another investigation or another process. But I can see there also second on the list is a GMC investigation, and I'd like to reassure you that many of the complaints that we look at and we assist members with are resolved locally and don't develop into other processes. But we know that complaints are stressful and time consuming for you to balance the work that's involved in investigating them and drafting responses. And you know, clearly patients are at it's a difficult time for patients as well if they're worried about their health and that they've had cause to raise a concern. So hopefully by the end of this session, you will be in a better position to relax a bit when you're handling a complaint and know, at least have a sort of framework for investigating it and responding to it. So many of you highlighted that you were concerned that another process might go on in relation to a complaint. And this is something called multiple jeopardy. And we do have a slide where it illustrates exactly what this is. And this is the slide. And you can see a single clinical incident can give rise to, and in red, we've got the complaint. And we've got the local resolution, and potentially there might be an Ombudsman investigation, and we'll discuss those, discuss Ombudsman investigations later on in the presentation. But you can see that a clinical incident can give rise to any of those things on the list, any of those processes, investigations. And we understand that is a concern for members, and the idea of getting it right at the complaint stage can also help if one of these other avenues that patients have to go down. It can help that, it can inform that process. So certainly reflection and learning at a complaint stage can really help to demonstrate remediation, for example, and that of course is very important if, for example, a doctor is the subject of a GMC complaint. I've put a slide in there about the Parliamentary and Health Service Ombudsman because this is these 6 points are what the Ombudsman says are the principles of good complaint handling. So they're important because some complaints, if a patient remains dissatisfied, will end up on the Ombudsman's desk. So getting it right, well, we've discussed, that's why we're here. We want to get it right. But the Ombudsman is also looking for the organisation to be customer focused, to demonstrate openness, accountability, acting fairly and proportionately, and be prepared to put things right. So thinking about implementing system changes, thinking about how a service can improve as a result of a complaint. So some of those aspects you want to try and cover in a response, so that if, for example, it went to the Ombudsman, you had got those things already included. But there are other reasons why it's not just in case the Ombudsman gets involved. There are other reasons why it's important to get complaint handling right, and your organisation will have an obligation to comply with the local authority, social services and NHS complaints regulations. So this talk is to you as English GPs working in the English jurisdiction. So I've included that relevant statutory instrument there. So there is an obligation under those regulations to comply, and they underpin the complaints procedures that you will have in your practice, your organisation. For example, there are certain timescales for complaining and responding. So the complaint should be made within 12 months after the date of incident or knowledge of a particular problem that might have arisen in a patient's care. So that's the complainant has 12 months. If a complainant is out of time, though, it is ordinarily our advice to respond if you can. And then you have 3 working days to acknowledge a complaint. And in that acknowledgement, you should be setting out how you will investigate it and usually agreeing a timescale for a response with the complainant. Now, there's no specific deadline except a 6-month backstop for responding to a complaint under the regulations. But of course, your own organisations that you work for will have their individual timescales, and they're often going to be much shorter than 6 months, of course, but that sort of 6-month window helps you if you need an extension because you're all very busy in your clinical work. Sometimes complaints are involving multiple different clinicians in a practice, in an organisation, and it's going to take time to collate individual responses and then to draft the response. But if a complainant doesn't receive a response within 6 months, then they can then go to the Ombudsman. I thought I'd just touch upon multi-agency complaints because this is something that we encounter in terms of our advice to members sometimes, and sometimes it's not clear to members exactly what they should do in this case. So this is where a complainant is complaining to your organisation, but also raising points of concern about another organisation that has been involved in their care. And the regulations require a coordinated response, and there is a duty for the different organisations that are named in the complaint to cooperate, and simply signposting the complainant to the other agency to complain to them is not enough. Okay. So if we move on to organisation at the practice, so this is again consistent with those regulations that I highlighted just before. A complaint can be made to both the provider or the commissioner, but not both. And I'm sure you'll all be aware in your own organisations that you'll have a publicised complaints process, so that's a must. And then each practice must have a responsible person for complaints and a complaints manager. So the responsible person is usually a senior member of the clinical team who will oversee the complaints investigation and the drafting of the response. And often that responsible person is the one signing off on that response. And then the complaints manager, maybe the practice manager or business manager, who assists the responsible person in the investigation of the complaint. And of course, you might need to consider a deputy. So, for example, if the responsible person is named in a complaint, you might then want to consider having a deputy responsible person for that particular complaint, so that the person having oversight over the complaint is not someone who was actually involved in the clinical sequence giving rise to it. There are other reasons why it's important to get it right, and of course the CQC have an interest in complaints, and they have actually examples on their website of what they would typically class as an inadequate rating, and that's where a complaints process is unclear, there's not an effective system in place to deal with complaints, and that there's no sign that there's a link to improving the quality of care of patients. But on the other side of the coin, there's an example of outstanding rating, and that's there in that quote in terms of gathering feedback from the people who are involved in the complaint, making sure that people are treated fairly, and also holding, services being held to account as well. And then, of course, as well as the organisation having a duty to deal with complaints, as doctors, in line with your ethical obligation, your professional obligation, and as set out in the GMC's Good Medical Practice, you have a duty to respond promptly and fully, openly and honest to complaints. And so that's your professional obligation. So what is a complaint? Essentially, a complaint is a expression of dissatisfaction, and there we've actually got the definition from NHS England. It may be verbal. So sometimes on occasions we might see somebody saying you need to put your complaint in writing. Well, that's not actually necessary. So somebody can make a verbal complaint, and then an organisation should have a facility to summarise the points of concern in the verbal complaint. And then a complaint might be written. It might be emailed. It might be via a complaints form. The thing about verbal complaints is if they can be, if they are simple complaints and both sides consider that they've been able to resolve it within 24 hours, then that's fine. Sometimes a written response is not required. But with all formal complaints that can't be resolved within 24 hours, then a response is required. And sometimes members ask us about having a meeting, perhaps with the patient, instead of drafting a response. And while you'll see from later on in the talk that a meeting can be a really good opportunity to discuss a response, to narrow down the issues concerned, it's not a substitute for a formal response. And certainly if doctors or organisations are having a meeting to discuss a complaint, it's very important that that the outcome of that meeting is summarised in a formal response as well. So I think I'm going to, at this point, hand over to Claire if she appears.
Yeah,
there she is.
thank you. Thanks for that, John. That's really, really helpful and sets up the second half of the talk very nicely. So I thought we would just put this slide in. The MDU gets a lot of complaints, and we assist doctors and other clinicians to answer complaints, and our practice managers, of course. So we look at these and we analyse them, and we seem to see recurring themes in complaints. And each one of these you will recognise, I suppose, and you could have had complaints about. They're all talks in their own right, and in fact lots of them we do have webinars on the MDU website that cover these topics. But the value of having this list in your head is that if you get into a situation where, for example, you're in a difficult consultation, you think communication skills are we're not reaching a shared communication or a shared understanding here. That's one of the things that the MDU says comes up during complaints. It might just come into your head and say, right, do you know what, I'm going to step back from this difficult consultation. We're going to take some time out to regain our composure, or I could arrange for you to see another clinician instead if you feel that you'd like to do that. So sometimes trying to head complaints off at the pass, if you know what causes them, sometimes you can actually avert them, and you can end that difficult consultation in a different way without it ending up in a complaint. So if you consistently get these things right in your own practice, you really should get fewer complaints. So we're going to have a look at a complaint scenario just for a few minutes. This is just typical. It's an amalgam of the sort of complaints that we see. So this is a complaint from a patient who's just been discharged from hospital. He had an operation for bowel cancer and he's got a stoma. He wants to know why he wasn't referred urgently when he came several months previously with constipation, and thinks that if he'd had that, he may have had a lesser procedure and not ended up with a stoma. He then faced some difficulty after his discharge with getting a prescription for the items that he needed for his stoma care, and said that one of the receptionists was not particularly helpful to him, and couldn't or wouldn't add the medication as a request, but said that he had to make an emergency appointment at the surgery. So you can see there's quite a bit to this complaint. There's a clinical part, and there's stuff to do with the reception staff. So what to do as soon as you get that complaint, it's clearly an expression of unhappiness if we think of John's definition or NHS England's definition. What to do is you acknowledge it. The times are slightly different in the 4 UK jurisdictions. In England, it's 3 working days to acknowledge. You should explain how you're going to investigate the complaint and tell the complainant when they should expect to receive a response. So that's the bare minimum for an acknowledgement letter, but it can be much more than that. So if you read this acknowledgement and then compare with the one on the following slide. So we're sorry you felt the need to complain. We will respond to your concern within 10 working days. So that's, I suppose it tells the patient what to expect. So it does fulfill the criteria legally speaking, but you can make it more. So I'm very sorry to hear you've had a diagnosis, such a serious diagnosis, and I'm sorry to hear about the difficulties you've had. I understand that your main concern is that you should have been referred to hospital sooner, and we're going to investigate that with the doctors who are involved. I know you may need to seek care from the practice. In the meantime, please be assured that that will not be affected by your complaint, and that can be really reassuring to patients to hear that. And I've set out below what I'm going to do to investigate the complaint. Please get in touch with me if you think I should do it a different way, or you want me to add to this. So that doesn't take much longer to write, but it is much fuller. It's already setting a tone of understanding and sympathy. And if you were the complainant that received the first or the second of those, how you would feel much better with the second. The other important thing is that sometimes complaint investigations take a bit longer than we expect at the start. They turn out to be a bit more complicated. So give yourself some wiggle room. Say, hope to get a response by the end of April. That's about 6 weeks. But if we don't get it done by then, I'll keep you updated and then make sure that you do, of course. So acknowledgement is an opportunity. For verbal complaints, it sets out and summarises, as John says, here's what we understand your complaint to be. You can deal with issues of consent. If you're dealing with a minor or somebody who doesn't have capacity, you can use this letter to say, we understand you've concerns about your son's care. He's 16 years old, and therefore, in order to reply, we'd like to get his consent for that. We'll still investigate, but we'd like his consent, and here's a consent form to help you do that, and also to manage the expectations of the complainant, so what they may or may not expect to receive and when. So good complaint handling. This is taken from the PHSO. I'm going to have 3 slides in good complaint handling that refers to their guidance, because again, they are the final arbiter of some of the more serious complaints. Listen carefully is really important. Confirm what the concerns really are and what they want to achieve. Manage their expectations, explain what you're doing and why, tell them when you're going to update them, and then make sure that you do that, and explain what will happen next. So that's all good complaint handling. So let's look at this letter in a little bit more detail, and I'm doing something here that I actually physically sometimes do. If I get a very complex complaint, I will highlight the bits that are really important so that I don't forget anything. And when we come to the section on actually composing a complaint response, where we get some practical tips on what to write, one of the most important is make sure you actually address all parts of the complaint. Don't pick and choose the bits that are slightly easier and less awkward. So I think there are 2 big bits here. There's the clinical bit. I think it should have been referred earlier, and then there's the stuff dealing with the reception staff. So just make sure that both of those get dealt with in the final response. So in order to investigate those, what you're going to need is an account from the doctor or the doctors who saw the patient earlier in their illness, an account from the receptionist as to what happened when he contacted looking for his stomach care products, and a review of the clinical management. So that means digging down into what was done, but also why it was done, and getting review from other clinicians as well. So basically taking it to a practice meeting. And the very best way, I think, to investigate complaints generally is to have an SEA meeting as soon as you can, because it gets everybody together, and it's a non-challenging way, I think, to look at complaints, rather than having the doctor in isolation go off and write a complaint response. And sometimes he or she doesn't understand what they're being expected to do. So what happened, why did it happen, what's been learned, and what's the change or what's the action? So always have an action plan coming out of this. When we ask or when we recommend SEAs, that is not in any way to say that something has gone wrong or that something has been done wrong. It is anything but that. It is saying, I have heard a concern, we are going to investigate the concern, we're going to act on the concern, we're going to learn from that concern, but that's not the same as saying we did something terribly wrong, because loads of complaints arise when really very little has been done wrong. The patient just doesn't either understand what's been done or doesn't agree with what's been done. So the second step of the Ombudsman's good complaint handling is share your investigation plan. So when you've got your plan together, use your evidence, explain what your sources of information are, and how you're going to evaluate those, and what your decision making is going to involve. So tell the patient stuff. It's very easy to, for this to be a very adversarial process, but genuinely patients tell us that what they want when they complain is to be heard, to understand what happened, and for it not to happen to other patients again in the future. So they want to see learning and changes to procedures and to practices. So sometimes there are complaints where the patient's recollection of events just completely differs from what the doctor remembers or the other people involved remember, and also from what's written in the medical records, and they can be very difficult to resolve. I would say there is virtually nothing to be gained to trying to persuade a complainant that they're wrong, but what you can do is explain in a nice way that what they're remembering is not quite the same as what the doctor remembers, and not quite the same as what's written in the medical records. And so round up your evidence and produce it dispassionately. It doesn't have to be, haha, that's not what happened at all. Look, we're really sorry. I think you may have forgotten this bit of the consultation because the doctor clearly wrote down A, B, and C. And just bear in mind that if the disagreements can't be addressed, they may not be resolved, but at least they can be addressed. It means the complaint may be more likely to escalate. So here are 2 different approaches. We've reviewed your complaint as a practice, and all the doctors agree that they would have done the same as Dr. X when you attended in March. So this is the complaint about the bowel cancer and the early diagnosis. So if you read this and then read a different response, what it says is, we reviewed your care as a significant event to see whether you could have been referred. we looked at the NICE guidance, and it says that if you're in your 40s, you can be referred in a 2-week wait pathway if you have unexplained abdominal pain and weight loss, or if you have blood in your stool on testing, and that's fit testing these days. When she saw you, Dr. X established that your symptoms were actually different symptoms. So that is also saying we would all have done what Dr. X would have done, because she followed the guidance, and there wasn't enough reason to refer you. You didn't have symptoms that were suggestive enough. So it's saying the same thing, but isn't it saying it 2 completely different ways? So no surprises here. When you write your response, we would always say have a beginning, a middle, and an end. And the beginning should be an appropriate introduction. Who are you? What's your involvement in this? And I am one of the senior GPs in the practice. I've been asked to investigate your concerns about your referral for investigation of bowel symptoms. I'm very sorry that you've had cause to raise concerns. So get a nice empathetic opening and explain what you've done to investigate the complaint. So in order to investigate, we've looked at your medical notes, we've had an SEA, Dr. X has written her account of events and her reflection of events. So that very first paragraph is saying, we hear you, we hear what's happened, we've taken it seriously, we're very sorry that you've had this experience. That is not the same as saying we've done something wrong. It's saying we're sorry that you've had cause to complain and bring this to our attention, but we're really going to look at it and learn from it. So the middle part, beginning, middle, and end. The middle is going to be the factual part that Dr. X is likely to write. So what were the symptoms? What did I think? What was my clinical thinking? Why did I order the test that I did? Why didn't I refer you? When you look back and think that was a point where you should have been. And then after the factual part, you look at the complaint and say, here, in response to that, here's our reply. The receptionist says A, B, C, and give your analysis of what happened and why it happened. You then will cover learning points or changes to anybody's practice. That's either clinicians or the practice protocols generally. So Dr. X might say that in future she, with people with unexplained abdominal symptoms, she's going to follow them all up, with a specific appointment in a few weeks just to check that things are settling for them, or give very specific safety netting advice, whatever she has learned from that. The end is saying, right, here's our response, but here's what you can do if you are still unhappy having read the response. So what do you do? We could meet with you to discuss any outstanding concerns that you might have. If you remain unhappy after the local resolution process is completed, then you have the right to escalate your concerns to the Ombudsman, and you give the contact details of the Ombudsman. So going back to the Ombudsman's own good complaint handling, is making and sharing your decision is step 3 in that process. Be clear and compassionate, provide evidence, say whether or not anything went wrong. So sometimes you do have to look back and say, with hindsight, I'm really sorry that I didn't refer you when you had those symptoms. And here's what I've done. I've gone and learned, updated my learning on unusual presentations of bowel cancer, and in future I will have a much lower threshold for referring somebody with that set of symptoms, even if they don't meet the strict criteria. So that could be what Dr. X says about her learning. Be clear about the decision and any action you're going to take as a result. So staff may be trained, your reception staff may need to be updated about discharge letters and who can action what. And again, you tell the complainant how to get in contact with the Ombudsman. So we would like to think that with a nice sympathetic approach and a good comprehensive letter, that most complaints, and probably in the order of 90% of complaints, are settled at a local level, and the complainant accepts the explanation and apology. Sometimes it takes a meeting to do this. So if the complaint isn't resolved, you have a look again at your position, have a think about a local resolution, and I'm going to do a slide or two on that, and have a think about what will happen if this goes to the Ombudsman. Meetings with complainants. What's the purpose of the meeting? The meeting is to see what is unresolved. So lots of stuff the patient may now understand and accept, but there may still be some things. They may still not like that the reception staff weren't helpful to them, or they felt they weren't helpful to them. So what are your outstanding concerns? What can we address for you? When can we do it? Where can we do it? So get a mutually convenient time and place. Allow enough time and have an appropriate venue. And sometimes that's the practice, sometimes it really isn't the practice. And who does the patient want to be there? Who does the practice think should be there? So all of this is negotiated well in advance with the patient. And I would say just at this point, we have a really, really good e-learning module on local resolution meetings on the MDU website. It is well worth a look for any MDU members. A really practical session on how to set up a meeting and get a really productive meeting. And I can think, I have had a case file running for about 2 years, I think, with a very persistent complainant who has been quite resistant to explanations and keeps returning back with other complaints. But that practice had a local resolution meeting last week with him and found it extremely useful. And at the bottom of it all, I think he was just scared. He didn't really understand what had happened and he didn't really know how to ask. So they find that really productive. Some of them, you know, they're stressful and sometimes they go well, sometimes they're slightly less productive, but at least you have given the patient the opportunity to ask the questions. So before you set up the meeting, contact the patient, say who will be there, what issues are going to be discussed, so have an agenda. The duration of the meeting is important, so a start time and a finish time, because sometimes they can run on much longer than people expect them to. Get the venue right, and who will be chair, who will be there with the patient as well. After the meeting, you will summarise the discussion and send the minutes in a letter and ask the patient just to agree that that's in accordance with their recollection. Tell them again what they can do if they stay unhappy. So we're moving into the last few minutes of the presentation, and I can see that we are getting loads of questions in, and I would just encourage you to get the remainder of your questions in there, anything that's come to you while we were speaking. So just a quick poll, and this is literally a yes or no answer for me, and it's, have you or I would say your practice or anyone in your practice ever had a complaint investigated by the Ombudsman? So that is literally just a quick yes or no. I'll give you 2 minutes for that. I think once you've had one, the process becomes familiar, but if you haven't, it is really quite an alien process to practices when they first encounter it. So I thought it was worth putting a couple of slides in at the end just to look at that. So it's 80% no, 20% yes, and that would be, yeah, that would be in keeping with any other polls that I've asked a similar question. So probably about 1/5 of you know what I'm going to speak about next, and 4/5 really don't. So basically, if the complaint is not resolved locally, the complainant can go to the Ombudsman. The first thing they consider is, can we actually investigate? So what that means is the local resolution process complete? And sometimes what happens is that the Ombudsman will say, well, if you haven't actually met with the practice yet, it might be worth just taking that final step to see if you can, you know, kick it to touch and get that complaint settled for you. Sometimes patients don't want to, sometimes practices don't really want to, but they can be really helpful. So can we investigate? And then should we investigate? Has there been some maladministration or service failure that has resulted in injustice or hardship for the patient? That's the words that they use, and anybody who's dealt with the Ombudsman will see all of those words in the letters every time. They then go into their investigation stage and they will get the entire complaints file from the practice. They may get independent clinical advice from their own clinical advisors, so they have doctors and nurses who will comment on the standard of care and say, yes, we think the care was good and we don't think a referral could have been made for this guy any earlier, or vice versa. And they have legal advisors who will advise them on legal aspects of their investigation. So when they finish their investigation, they will write to the practice again and say, here are our draft report and our draft. So in that they will say, we are minded to uphold this part of the complaint, or we're not going to uphold this part of the complaint. Now this is a really important stage for practices, because this is really your last chance to influence the Ombudsman's thinking and to present any further information. So sometimes they don't apply the same weight to certain bits of evidence, or sometimes they don't see things, or we think we've sent them stuff and we haven't. So what you could say is that we don't agree with the clinical interpretation because we've just had a look at the NICE guidance and here's what it actually says. So that might be slightly, you know, you might want to have a look at that bit. So there's a bit of negotiation can be done at this stage if you're not in agreement with the findings and the recommendations. The turnaround time for that is really short. 14 days goes very quickly in a general practice, and these complaints are by definition probably some of the most complex ones. So jump on that. The Ombudsman is sometimes amenable to extensions to that, but they're generally short extensions of the region of a week or so. They're not big long chunks of time to review everything again. once a report is finalised, that's pretty much it from the practice's point of view. And the Ombudsman, as well as saying we uphold the complaint, will then make a series of recommendations, and they will often include things like an apology for any maladministration that they think has been done or any injustice that has arisen. They can award financial awards, not huge sums as you might achieve through clinical negligence claim, but sometimes they're substantial for practices, especially small practices. And they can ask for evidence of change and ask practices to demonstrate that they've learned from the complaint and that things would be different and that the same injustice doesn't happen to another patient in the future. So that's basically just a thumbnail of that, so that if you do ever have a complaint, go to the Ombudsman, at least the terms will be familiar, the process will be familiar to you. So we're now going to move on to the interesting part of the talk, or hopefully the more analytical part of the talk, and that's where we actually get to answer your questions specifically. John, I think, is going to kick off. You've been monitoring the questions while I was speaking very kindly. So do you have one to start us off?
There's been a lot of questions, so I've been beavering away trying to sort of capture them into certain topics. I think that might be helpful. But first of all, a lot of people have asked about whether there will be a recording available. Yes, there will be of this presentation. We don't ordinarily provide the slides, but we do have some resources on our website, guides on complaints handling, writing a response, which you can also have a look at. So I think it might be quite helpful to start off with the acknowledgement part of the complaints process, because we've had a couple of questions on this. One of them has been, so if a patient expresses dissatisfaction, but they say they don't want to take it further as a formal complaint, is that okay? And of course, that's, the acknowledgement part of this process is a really helpful opportunity to understand what the patient's expectations are, and you might be able to very simply resolve somebody raising a concern. You might be able to resolve that without a formal process. So that could be very important. And somebody has also asked, well, who does that acknowledgement letter? Who sends it out? And ordinarily, our experience is that the complaints manager, who's often the practice manager, will make sure that that's done within the 3 days. But importantly, sometimes it's really important that in that acknowledgement letter, it sets out the understanding of the complaint, so your organisation's understanding of the complaint, and also gives the complainant an idea about how you're going to investigate the complaint and timescales. That's very important.
Yeah, I would say just the timescales are a point that come up all the time, because we see, John, lots of practices have standard acknowledgement letters, which are absolutely fine, time-saving and are perfectly good. They tend sometimes to tie themselves to a specific time to respond. So they will say we will respond within 10 working days. Now, as John went through the regulations earlier, that there is not that tight a time limit on this. So don't feel you have to have a very short turnaround time for complaints. You can leave that much more open-ended, because some complaints are more complex than others. So I think you don't have to have an actual time in your acknowledgement letter, but you give people an idea of when they can receive or when they might receive a response, and the fact that you keep them updated if that slips for any reason and you can't make it by that time. So I think that might be a more fluid way to do it. And sometimes we see practices tying themselves in knot because they can't get to the 10-day deadline and they start to get really stressed, but that's a kind of self-imposed deadline.
Absolutely, Claire. We've also had a question about whether the complaints correspondence should form part of the clinical record, and the simple answer is no. That the clinical record is for the clinical care of the patient. The complaint and the documents pertaining to the complaint should be kept in a separate complaints file. That's right, Claire, isn't it?
Yeah, absolutely, yes. The purpose of the medical record is just any information that informs the ongoing clinical care of the patient, and complaints don't really relate to that. So in general terms, a complaints folder where the complaint is completely separate is a much more sensible option.
And we've had a question about if a patient records a consultation covertly, can they use that to complain? Well, they can, yes. So patients can record consultations and they don't need to tell you that they are. So I suppose our advice should be that always think that the patient may be recording you. But of course, sometimes a recording can be evidence of good practice. Often it is, so and can be used by a doctor or a practice to respond to a complaint. So thinking about how many calls are recorded to practices nowadays, you know, you can, if a patient has said something was discussed during a call and you have a recording of it, of course that is an avenue you can look at when you're investigating the complaint.
Yeah, I think in general terms, patients are on, we're all walking around these days with high-powered recording devices in our pockets. So I would almost say assume that you're being recorded most of the time. And patients do it for lots of reasons. They do it because they know they're not going to remember everything the doctor said. I think they don't purposely go out to trip people up, but they often have recordings, and sometimes they pop up in, you know, in complaints investigations. But I would say 99% of the time that we hear them, they're protective for the doctor. They show that it is, you know, what the doctor's account of events is held up by that. So I think try not to be fearful of that. They're generally helpful.
Yeah. And another question we've had asked is what happens when you get into this sort of scenario where there's back and forth? So a complaint response has been served, and then you know, another complaint, a second complaint about the same thing comes in. I suppose the most important thing is that's an opportunity to review your position in terms of your original response. So the things to look out for would be, are they raising new points of concern that haven't been addressed, or perhaps they're raising points of concern that you might have overlooked in the first response. And also, it would be important to consult widely within the practice in terms of you perhaps discussing a second complaint with certainly the complaints manager, the responsible person, any other clinicians who are involved, and considering whether, in light of the second complaint, does it cause you to change your position that was set out in the first response? Is there a possibility that you can evidence further reflection or learning? But it does reach a stage, doesn't it, Claire, where you might say, well, you know, we really have tried our best with this response, this complaint, and we don't have anything else that we can offer at this local level.
Yeah. Yeah, so those are the times when it's actually the practice that's going to say the local resolution process is now complete. We can't give you anything else. It's not very common. Generally, it's the patient who says, I'm still not happy, but there's absolutely no obligation on a practice to respond repeatedly to the same concerns, or to the same concerns dressed up slightly differently. You give your response. If the patient raises something new, then of course respond to that, but you're quite entitled to write back, we've issued a response to that, and we attach that for your review, and we don't believe we need to add anything further to that at this stage. And you know, at that stage, sometimes you just have to draw a line under things. Of course, we're going to really do our best to settle things locally, but unfortunately sometimes that just is not possible.
And I've also seen a question here about whether you can remove a patient from your practice list if they complain, and that's actually dealt with very clearly in the GMC guidance, that you know, you shouldn't be ending a professional relationship with a patient simply because they've made a complaint. So that advice has to be very clear, and certainly, you know, doctors can get into difficulties if a patient is removed and then says that claims that the reason they've been removed is because they made a complaint.
Yeah, and that's the thing, because sometimes complaints come after very difficult encounters with patients, and we would say that if you remove a patient during a complaint process, it can look as if you're removing them because they complained, whereas that is not the issue at all. The issue is they were aggressive and shouting at your member of staff. So what I would say is settle the complaint first. If you then think you need to send a warning letter, if this is aggressive behaviour that you can't tolerate, do send it, but you know, separate that completely from the complaints process, so it's very clear that you're handling the complaint that would be dealt with impassionately, but that the behaviour also has to be addressed just separately.
Yeah. And we've had a question here about complaints made by patients' families where the patient is deceased. And I suppose we should also cover here, Claire, when a patient lacks capacity and a complaint has been made about their care.
Yeah, these come up all the time. So we have a duty of confidentiality that the practice does to patients even after they die. You can't just open the medical records and say, right, here's everything. But the JMC says that if a close relative comes and asks the practice, I don't understand what happened to my relative, can you explain that? And sometimes that is framed as a complaint, as in I am unhappy with what happened. In general terms, you would be expected to explain that and to provide enough information for them to understand and for you to reply to the complaint. There are also times where relatives can access the entire medical records, but that's a slightly more specialised area to do with their legal representative, and we would advise you about that separately. But complaints, yes, generally you would answer complaints about deceased patients. Moving on to patients who lack capacity, sometimes they would have capacity to understand that a complaint has been made, and in general terms it's in the patient's best interest. So if a patient lacks capacity, a practice will always act in their best interest. Generally it's in their best interest to respond to a complaint, and again what you would do is limit the information in there, the very sensitive medical information, to the minimum necessary to address the complaint, and try and involve the complainant or try and involve the patient as much as possible, even if that's not going to be a huge involvement. But say, you know, your daughter's complained about your care, we're going to try and address those complaints. Are you happy for us to do that, and see how far you can get with consent?
We've had a question from somebody saying many of my practice complaints are sent in by email, but I call the patient to discuss. If they say they are happy with our discussion and don't need a letter, do I need to send a letter anyway? And I suppose this links in with what I was talking about earlier, and the acknowledgement part of a complaint. And it's finding out what the patient's expectations are. I think if you've got a patient who's raising a point of concern which you've been able to address and they're satisfied with it, they indicate that they don't want to take it further, then that's fine. But I think you would need to explain what taking it further meant, and that what formally investigating the complaint meant, because that they might want to have a response, but I'd certainly want to sort of gauge what their expectations were, what their understanding was of how their point of concern could be further investigated and responded to. Would you agree, Claire?
I would say very much so, John. I think because the regulations say a written complaint must get a written response, I think you have to be very careful to make it really clear. So you would need a paper trail or a document trail to say, so if you speak with the patient and they say, look, it's fine, I'm happy, I wrote it, I was really upset, and now I understand, I was just blowing off steam. Write them a letter that says, I'm glad you found our discussion today productive. Please be aware that if any stage you want a written response, we will issue that for you. So what you're doing is saying, we know what we're supposed to do. You're telling us not to do that, but we're keeping the door open for you. And what I would say is that there is a world of difference between, between issuing a written response and or not issuing a written response and not investigating. There's nothing to say you can't still do your SEA, so then you'd have the minutes of that. Have a look, see what you can learn. So if the patient does decide in 2 or 3 weeks, yeah, it's still bothering me, I do want to come back to this, you've kind of done the groundwork for a complaint response anyway, you've done your learning. So I think all complaints should be looked at SEAs, even, just a quick chat, and even if they do resolve very quickly.
Absolutely. And I don't think we actually explicitly said at the start of the presentation, but while we're sort of giving some very general advice about complaint handling here, if you have you know, a specific case, of course, you can contact our advice line. You can email us and request assistance with it. And I think somebody has asked in one of the questions, you know, when does the MDU sort of step in? And of course, members contact us about complaints that they're named in, and we can provide advice on the complaints process, how they might investigate the complaint, but also we can advise them on draft responses as well.
Very much so.
Yeah.
And we would say if your ears are twitching, if you get a bad feel about a complaint, if you think this one has legs, then I would say contact us early rather than later. We all recognise the sort of single issue, easy to address, or usually easy to address complaints. I think if it's a complex one, we're always happy to see, have a look, give you some written advice on the responses. Yeah.
And we've had a question about if a family member tries to make a complaint about a relative, if the relative has capacity and doesn't agree and doesn't want to make a complaint, can this complaint just stop at this point?
Yeah, I would go right back to what I said in the last one. I would say investigate anyway. I would say, and what that will do is placate the complainant, because what you're going to have to do is go back to them and say your relative is not letting us issue a response to your complaint, but please be assured we will be discussing it at a meeting. We'll be identifying learning points. We will formulate an action plan. So what they're doing is saying we are taking it seriously, and sometimes that can be a little olive branch if you can't give them what they really want, which is a full-blown explanation. But that's the absolutely right approach. You would need the patient's consent because all the information is about the patient.
Yeah. Okay. So I'm just having a final look through the. I'm aware we've got 3 minutes left. I'm just having a look through the other questions that have been coming in while we've been discussing those. Just having a look here. Oh, perhaps one final question. Somebody said that they feel that there are more, or there have been more NHS England complaints or complaints coming in via NHS England. So perhaps we could just touch on that aspect of complaints.
Yeah. As you will know, in the last year or 18 months, complaints handling has been devolved to the ICBs. Mainly, and it may just be that complainants are more aware of that, so that they know that they can go to the ICB. So complaints at a local level are made either to the commissioner of the service or the provider of the service, so either to the ICB or to the practice directly. You can't go to both, or you can't go to one and then the other. So it's either of those, and then up to the Ombudsman as the second stage. But yeah, and they do seem to be more frequent than previously. I will just say that the clinical reviewers part of the complaints process still remains with NHS England for present. So what happens is if the complaint is about clinical care, the ICB will send it to the practice, say, can we have your response? They will then send it off to NHS England for one of their clinical advisors to have a look and give an opinion on the standard of care. So they're still involved, they're just in a different way.
Okay. Well, I think we've managed to cover most of those questions. So thank you very much, everybody, for attending this webinar. We really hope it's been helpful. And as we discussed earlier, the recording will be made available and you will be able to receive a certificate. So thank you very much for spending an hour of your evening tonight with us.
Thank you. See you soon.